All right, we're live. Welcome to this afternoon's discussion on Groundhog Day. So, where would the group like to start?
Start with Bill.
Bill? All right.
Which one?
Yeah.
Well, the big guy.
We need some clarification.
What's up?
What do we listen to on like the weather? Do we listen to when they hold it up to the ear, or do we watch them come out? Like the ground, and does he see a shadow or not, or do we like?
I think we watch his behavior. Is that what you're asking?
Yeah.
I was
Okay.
confused about that too.
It-
Because I feel like in elementary school.
It was,
like he sees a shadow.
Yeah.
yeah, but in the movie and like, I guess this event,
The real
they push the groundhog out of the thing and hold it up to the ear.
Yeah, I think they may have had to embellish a little bit to make it more theatrical, but it's usually just the behavior, which actually does have a parallel to psychiatry, and that is it's much more important to observe how people act and perhaps on several occasions put stock in what they're actually saying. Right. I mean, we deal with that a lot in psychiatry in terms of making sure that their nonverbal communication resonates. Right. So, I mean, easy parallel there. What did the groundhog tell us in terms of seeing a shadow versus what did, I'm not even sure the individual's name who was hosting the event, tell the crowd with regard to the groundhog seeing a shadow? Because there might be two different things, which again, is not unlike what we experience in the field of psychiatry. Nonetheless, we're focusing on the weather person, Phil, that Phil.
Mhm.
So, what did you observe? What do you want to talk about? Our favorite neighborhood meteorologist.
He's pretty much right away as being universally disliked.
Right. Okay. Does he seem to care? Not at all.
Very narcissistic, like he's ready to move on to like the next big thing. Like he's already leaving the station and go to a bigger one, better one. It's like he's just kind of, yeah. It's like just like a very narcissistic look at like nothing else matters aside from me.
Inflated self-importance, yeah, which is a trait of the narcissistic personality disorder. So we could certainly look at aspects of empathy or lack thereof, and related signs that would be suggestive and perhaps defining of narcissistic personality disorder, right? Which he may actually reach. Now, personality disorders in general are enduring patterns of behavior, meaning that their onset is usually during childhood and or adolescence, and most people believe stabilize at or around young adulthood, emerging adult, 25, 30 years of age. We wouldn't expect individuals who have an established personality, for better or for worse, and that includes people around this table, to really change who they are. It's usually a static process. There are other aspects of a personality and therefore a personality disorder that we probably should discuss as well. So what are the other traits, defining principles that apply to all of the personality disorders, other than there being enduring?
Pervasive. Like
Yeah.
it's not in any one setting.
Right. So, I mean, what would be a kind of a cool YouTube clip, since this is exactly where most people go with Phil. We went right there immediately after being a little bit of controversy with the groundhog itself. But having a YouTube clip when Phil actually goes home, and he quote becomes a completely different person. It would be kind of a nice twist, but a major teaching pearl. And that what he demonstrated does then has nothing to do with his personality, and therefore is unlikely to be, I mean, significantly unlikely to be due to a personality disorder. So you create that clip, send it to me, and we'll do something with it. What else? What else about personality disorder should we kind of address that that apply across the board to all of the disorders published in the DSM? So that's debatable. I know that your board techs love this stuff, but sure, they're often egocentric.
But you would say an experience that maybe. That's not.
Not always true, right? In clinical practice, right?
They're disruptive to the social how the person operates, essentially.
Absolutely. They're clinically significant like any disorder, whether we call it schizophrenia, whether we call it major depression. Personality disorders must also result in clinically significant distress or impairment. Anything else? They cannot be due to the physiologic effects of a substance, just like any other mental disorder, an underlying medical condition, or another mental disorder. I mean, if somebody like Phil were found to be acutely manic, you would want to treat the mania first before rendering judgment on his personality, right? So those are the things that would apply across the board to all of the personality disorders. Right? With regard to any of them, is there something that might suggest that maybe he doesn't have a personality disorder at all?
It changes by the end of the movie.
He does, doesn't he?
I mean,
I think
it's implied that it
it
changes.
changes a lot. See it.
Right, yeah, we don't know the sequel, yeah. But if he does change, is there other parts of this film that then we could interpret that would be evidence-based as suggesting that, you know, this wasn't due to a personality? Why does he change?
People like him.
And like realizes that he's like, making mistakes over and over again.
Mhm.
So like, not distressing him, like no longer syntonic, like now something that he's reflecting on.
He wants to get out of the cycle.
Who wants to,
Get out of the cycle.
he does,
And he would also like to date
Yeah.
Rita.
Rita,
Rita.
yeah, he does. Anyone think he might have been depressed? I mean, he looks like he's in a midlife crisis. Right. He what? He did attempt suicide. Now, again, obviously it's a nuance there, but again, just to kind of test this hypothesis, if Phil then presented to you and you called me while taking call, and I said, well, what do you think is going on? He said, well, he's just in a continual loop where he keeps on reliving the same day over and over again. So I don't think there's much to it. I think he's good to go home. I don't think I'll believe you on call. Right? I'm thinking that with the suicide attempt, I probably would go in a different direction. So he did attempt suicide. Matter of fact, he may have, I mean, completed suicide for all we know. Again, a little bit of a twist there. So talk to me a little bit about the Ericksonian stages and what stage of psychosocial development our protagonist, well, antagonist turned protagonist is progressing through.
How old is he supposed to be?
I would guess mid-40s.
The verses one.
Yeah.
With that,
There's the verses ones, like
Yeah. I have it right
yeah,
there.
like
Something
blank
versus
verse blank,
stagnation.
yeah.
so before you look this up, I need to know what Erickson's favorite color is. So we're going to go right to left, and everybody's going to get a guess.
Right.
In all honesty, I wouldn't have considered that you may have spoken to him. This is just a pure guess. And unless I say it, it's an incorrect answer. So you have to pick a different answer. Then is it red or blue?
Yellow.
White.
Black.
Orange.
Pink. Purple. All right, we have a couple of repeats. Unfortunately, it's beige. Yeah, it's amazing. It's actually in his memoirs. What's also evident in his memoirs is that Erickson was an incredibly poor speller. I mean, he really stunk. So he actually spelled beige, B-A-I-G-E. But luckily for us, that it's actually the acronym to remember the 8 stages of his theory. Right now, there are 4 A's. Yeah, thank you. There are 4 A's. Now redo the math with 4 A's. Right, it does come to 8, right? We could discuss them later. But for Bill, what are we thinking in terms of midlife? So middle adulthood. I think I heard half of it,
Something versus stagnation.
right? Generativity, there's your G. and versus stagnation. And just to kind of test this little acronym hypothesis, what's the last or stage for older age? Lot of murmurs. It's ego integrity versus despair, right?
And
Right.
yeah, I was cheating. so-
Right. Right. All right, so we have someone who, per Eric Erickson, might be in stagnation. I think the layperson would refer to it as a midlife crisis. I think in psychiatry, major depressive disorder. And it might lend some explanation as to why he resolves or appears to have resolved the crisis upon completion of this one very long day.
Could you also argue that he's like in intimacy versus isolation because he's like hoping to date Rita and then eventually I realized that he needs to change in order to become intimate with somebody?
Yeah. So for intimacy, we're going then maybe regress back to the stage prior, which would have been young adulthood, intimacy versus isolation. Sure. And of course, very similar to Kubler-Ross discussed, albeit briefly this morning, even Ericksonian stages are not perfectly linear. So sure, he could definitely have some intimacy issues or have regressed back to that point. Again, in the prequel, we would not, I don't think, be at all surprised that he would have difficulty establishing meaningful relationships. Other thoughts about them? Oh, and by the way, if he actually presented to clinical attention and if you provided a biopsychosocial treatment plan and his depression resolved, we would expect that his narcissistic traits would also improve. And if not, of course, then we may actually be dealing with a personality disorder. But they did seem to improve by the end of this film.
There's a scene where he goes to get medical help, after Rita advises him. He sees a neurologist and psychiatrist, and he sees a psychiatrist. The psychiatrist is, obviously taken aback. And I'm wondering, in clinical practice, we're often told, when you listen to a patient's illusions, you want to acknowledge without validating them. So let's say in a hypothetical scenario, a patient came to me and said, "Doc, I'm repeating the same day over and over." Would it be clinically harmful to be like, "I'm going to tell you something that you wouldn't know unless I told you, and then if you see me again, you tell me that and I'll know"?
Not without going through the more traditional approaches first, probably, right? And which is exactly what you had stated, right? And I think everybody picked up on the subtlety here in that this particular character's difficulty is, in fact, and has always been, his repeating the same day over and over. Hence why he is in that middle-age crisis stage of generativity versus stagnation. He woke up one morning and looked in the mirror and asked himself, "Is this it?" And he didn't like the answer. Right. So midlife crisis, call it what you want, stagnation, but repeating the same day over and over. Now, of course, it takes on a dramatic tone in the film, but I think with regard to what you referenced to, the neurologist was right on point. It's always very critical, very important to investigate and rule out underlying neurological or medical condition until you provide a psychiatric diagnosis, until you make that referral. They did, perfectly accurate. The script is correct. I think the role of the psychiatrist could have been a little better. I'm not really sure the psychiatrist would have been that shocked to hear what sounds to be a psychotic dissociative cluster. It's hard to envision a psychiatrist not having that type of training. Nonetheless, the way in which the referral was made is actually accurate, right? It's good to see that somebody got it right.
What modality of therapy still calls for laying supine on the couch?
I'm not really sure that's really done. Even people, even non-MDs who are in the field of psychology and even social work that provide therapy probably don't have people recumbent. But that said, if there is a place for this, my guess is that it's probably analysis, that's psychoanalysis. Which again, I think the psychiatrist himself probably would benefit from in this movie. So you're the psychiatrist. what are your thoughts now, beyond the obvious, which is what we already discussed, maybe you're depressed, given the actual chief complaint? And we moved on. This is not a metaphor. This is a person with the belief that the day is actually repeating when he wakes up each morning at the same date on the calendar.
Depending on level of impairment, we could consider delusional disorder and length of, how long he's held that belief.
Yeah, so in just forming our thoughts, that is providing a case formulation. The first step is to always consider whether or not we're dealing with a mood anxiety spectrum versus a psychotic dissociative one. And it sounds like most people would say this is a psychotic dissociative spectrum. And then further processing this, if we just arbitrarily choose to start with schizophrenia, might he rule in? What are the 5 inclusion criteria that define schizophrenia?
Disorganized speech.
So disorganized speech,
Hallucinations.
delusions,
Thought.
thoughts and speech are the same. Negative symptoms
Organized behavior.
and behavior, right? Perfect. So again, just for review, and you nailed all 5 of them. So there's disorganized speech or thought process, grossly disorganized or catatonic behavior, delusions, hallucinations, and then negative symptoms, right? The pathological absence of something that at baseline should be there, negative symptoms. You're only required to have 2. Does Phil rule in?
But he is like his behavior is certainly disorganized.
So if you believe that his behavior is disorganized, he's clearly delusional. So the answer is yes. So then my next question is then why isn't Groundhog's Day or Groundhog Day a fictional case of schizophrenia? So the timeline's definitely, well, we kind of lost the time. Did anybody count how many times he repeated?
It's implied that it's been more than you even see, because like when he talks about it, he also like alludes to things that you never actually see on screen.
Yeah.
So like unknown.
I didn't write the number down, but I actually got the number off of Reddit. So people have geeked out. I'll tell you later. I actually forget it, but I actually did look it up. If it's, I tried to do it last night, but being in the East Lecture Hall and I couldn't do it. It's too dark up there. And Kathy wouldn't let me turn on the lights. So the timeline has to be considered here. But at this point in our in our case formulation, we have to remind ourselves that this condition, schizophrenia, is a diagnosis of exclusion. So you got to tell me the 5 illnesses that we have to investigate, because if any one rules in, it actually takes precedent. So a substance-induced psychotic disorder, good. Delirium. So that which can be due to an underlying medical condition. That's 2. 3 more.
Disorder with psychotic.
Mood psychotic, good.
Intoxication.
Substance use. 2 more.
Medical condition.
2 more. Delirium. We said.
Uh,
Schizoaffective, good. Well, and mood disorder, yeah. We said. The other one is a autism spectrum disorder or ASD. Any evidence of any here?
Well, we're saying his level.
Yeah, this may be MDD with psychotic features. Right, and if we're thinking that he might be depressed, and we discussed perhaps why, I think we would want major depressive disorder with psychotic features as our provisional diagnosis, and I think schizophrenia kind of moves off our differential list. And if we want to keep it on just for completeness sake, just to make sure we vet everything, but it's going to be low in our differential, especially with its atypical onset, meaning mid-40s. Right. The final step in the process is just a quick kind of experiment. If you had geeked out and taken notes, and if you now crossed on your notes page everything off that we've already discussed, would there be anything left? Because if the answer is yes, we have more to explain. That is, we have to kind of create, if not a differential, maybe think of secondary, tertiary diagnoses. So.
Is there anything else we noticed?
Is there anything else you observed in this movie that is not readily explained by anything we've previously discussed, including where we started the conversation with the narcissistic personality disorder, primary mood disorder, and psychotic features?
Wonder if there is, an element of like obsessive compulsive. As to the way he repeats it's the same interaction over and over and over again,
Hmm.
until you get the like quote unquote right.
If you interpret the movie like that, okay, so we have to consider that. I think that that's that consideration, I think, would also bode well for our patient in that if we are thinking to start an antidepressant, we might want to consider an antidepressant that has an alternative indication for obsessive compulsive disorder. So something along the SSRI class.
He exhibits hedonistic and antisocial behaviors after a time and destructive.
Yeah,
So if you want, like,
yeah, so something to consider here too. I don't know. I mean, we may want to include that in our case formulation. I don't know if we would do anything much different than we're already doing with the narcissistic personality potential, in that we treat the depression and follow the traits and see if they actually resolve. But that is another set of, they are another set of traits. That is another set of traits that
Would
we,
change the management. I also thought that maybe this was reflective of mania, and then it would change your management, right? 'Cause then-
Oh, yeah. Yeah, well, I mean, yeah, I would, because there are antipsychotics that are also FDA approved for the treatment of mania. And certainly we would want to choose one of them in addressing the psychotic symptoms. Even with MDD with psychotic features, the treatment plan is probably going to be a combination of antidepressant plus antipsychotic. And in the case that you're entertaining mania or a mixed state, then antipsychotic should be one that's FDA approved for the treatment of mania. Right. Now, the role of the antidepressant gets a little concerning, because if we do believe this is mania, the antidepressant really has no role here. Matter of fact, it could worsen the condition. So that's a consideration.
About like PTSD picture, going trauma, like it's reliving the moment, and they're like hypervigilance.
Right. So another interpretation of the actual repeating of the day is he re-experiencing, and if so, is this consistent with post-traumatic stress disorder? And the answers depends on your interpretation of this movie. And along those lines, I mean, you've tackled now 2 anxiety disorders, and I think the management in such a situation will be very similar to when we considered OCD as a co-occurring symptom or disorder. Any other final thoughts on Phil? So I think that's pretty much where we can land here, is that this looks to be a primary mood disorder with psychotic features. By the way, can we, I mean, if you were asked what type of psychotic features, how would you describe the psychotic features? What are some clinical terms we might want to consider here?
Delusions, grandeur. If he thinks he's like more important than he really is.
I think that's fair.
Sonic persecutory delusion.
Not somatic, not
Yeah.
jealous. How about the fact that he has or demonstrates clinically significant distress with deja vu?
Seizure?
Oh, always a delaying medical condition. Yeah, we always have to consider that, but the neurologist tells us that he's okay. Clinically significant deja vu has a name of derealization. Right, and if we're independent of any mood symptoms, for example, then depersonalization, derealization disorder. So it's something to consider as well. Not that you have to have a co-occurring disorder, but just further defining the quality of the individual's psychotic features. I do think grandiose is accurate, but I also think there might be an element of derealization here as well. Any other characters you want to discuss? Groundhog Day. The morning after. All right, let's talk about bipolar then. And so let's say, as part of this differential, somebody tell me the difference between bipolar 1 and bipolar 2.
Bipolar 2 has to have many and depression, but bipolar 1 don't have that.
Right. Any idea of what percentage of individuals with established bipolar 1 have a manic picture only? It's low, 10 to 20%. 10 to 20%, right? About 80%, 80 plus will have both. Okay, so if bipolar 1 is defined through the individual having had a manic episode, somebody tell me what a manic episode is.
Clinically distressing. Like, yeah.
Yeah.
Reaching stage fast, clinically distressing, impairs your day to day,
How long?
first 7 days. Or if you like require inpatient hospitalization.
Right.
Qualify as man.
Right, I mean, if they're demonstrating those symptoms, dig fast for 6.5 days and you get them to APS and all of a sudden they get loaded with valproic acid and within hours they're feeling better. Unfortunately, that does not escape a diagnosis. All right, so bipolar 1 is defined through a manic episode. Give me, with the exception of substance induced and that due to a medical condition, give me the one illness that an individual can be diagnosed with having had a manic episode other than bipolar 1.
Schizoaffective.
Good, right? Schizoaffective bipolar type is the only time that could happen. Right? Otherwise, if an individual has ever in their life suffered from a manic episode, 7 days of dig fast that is clinically significant, they have a diagnosis of bipolar 1.
Would
How-
that then mean that they're bipolar with psychotic features? Like if they're not having depressive features, they're manic with psychosis. Oh, but it'd be persistent throughout. Never mind.
Yeah,
What if it's like a brief psychotic,
brief psychotic disorder.
like it lasts 7 days?
If an individual meets criteria for dig fast and it's 7 days and it's clinically significant, they have bipolar 1. The only time they don't is if it's drug induced, that due to a medical condition or schizoaffective disorder. It's the only scenarios. Hypomania differentiates from mania. How? Time course, more specific.
3-4 days.
Right, so at least 4 days, but the bigger deal is that it's not 7. Right, what's the other way this condition differs or separates from mania? Right, does not impair function, and it is one of 2 illnesses in the entire DSM that is defined by it not being clinically impairing. What is the other one? Huh? So that's tricky. A delusional disorder is actually clinically significant. The APA actually has a little bit of vocabulary, and I think that's what you're getting at, that except for the impact of the delusion, the individual's functioning is not otherwise impaired. But they're significantly impacted by the delusion. It is clinically significant. No, no,
Obsessive compulsive personality.
no. A frown just came up your face. Is that your reason why?
Huh?
I said a frown just came
I was
across.
just not
your-
I look
No.
sad when I think.
Mild neurocognitive disorder separates from major neurocognitive disorder, the condition previously known as dementia. Same signs and symptoms, same cognitive deficits. But in mild neurocognitive disorder, by definition, it is not clinically significant.
Some like mixed messages come up with like the Montreal Cognitive Assessment, when you're looking into that. What's like considered the real cutoff for, I've seen 26, I've seen 23, I've seen 24.
Okay.
Is it like, do you look at it in context of like patients' educational status and like, is like that can affect it, but like what's like the cutoff for like impairment? Is it 26 or
Right.
23?
That's a great question, and I know what you're getting at. And I can't even tell you what I've used, because I don't remember last time I used it. And I don't know. I really don't know, because I've seen it published differently.
Yeah,
Yeah.
because it varies.
Maybe mental status is less than 26, and I think the MoCA might be 24. Let me see.
Yeah, I've just seen it in a bunch of like 26, 24, 23.
So you're talking about the Folstein?
Hmm?
Were you talking about the Folstein or?
The Montreal
Montreal,
and
yeah.
then the mini mental. So let me just check, if I had some book also. Yeah, see now. Condition is by the NIH.
in 2021. Traditionally, the minimum status, blah, 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 using a 23, 24 cutoff value. So, yes, 26.
Maybe
and
26
26
is
okay.
At least that's what I remember. Well,
So the impairment for MoCA is less than or equal to 26. But it
Okay.
also says the cutoff score has a low specificity of 31%.
Wow. Oh, right. All right. Somebody tell me the difference then between bipolar 2 and cyclothymic or cyclothymic disorder?
That's what I'm about 2 years and more.
And don't you technically not, you have like symptoms of both depression and hypomania, but you don't technically fulfill the criteria for them?
You do fulfill the criteria for hypomania, but what you said about, yeah, and that, you'll hear the clinical term, minor depression used to describe that. Right? All right, so, individual comes in with, a manic episode bipolar. What are your treatment choices?
Mood stabilizers.
So you're gonna go with a mood stabilizer. All right, generally speaking, there are 3 classes of mood stabilization.
Lithium,
Lithium's in a class by itself, right?
anti, convulsants.
All
Yeah,
right, so AEDs are anti-epileptic drugs, anticonvulsants.
and second gen. Antipsychotic.
We'll say antipsychotics because chlorpromazine is actually FDA approved. That's a first generation. So otherwise, you're right. Everything else from that list is from the second generation, from the atypical antipsychotics, right? Indication for the antipsychotic? Like, when would you use it?
Psychotic feature.
Yeah, most people do use it, and if you look at the Texas algorithm, in addition to, usually not as monotherapy, but as in addition to another mood stabilizer, lithium and/or an anti-epileptic drug with evidence of psychotic features. So for quote unquote severe states, which psychotic features is the easy operational definition.
And what's first line? Antipsychotic, is it olanzapine or quetiapine?
They're both first line. They're both FDA approved.
If you have acute agitation on top of the psychosis, like I think I saw something there where olanzapine or a benzo, but you could do the benzo just for the agitation, but then would you also be giving it on top of starting an antipsychotic?
Yes.
So would the olanzapine be better for the acute agitation with a benzo, or does it not matter which second gen you're using with the benzo?
You're probably going to go with dual therapy. And again, that would be a combination of the anti-epileptic drug, and for agitation, that's usually valproic acid plus the antipsychotic. And if there's agitation beyond that, then I think the third therapy you would put on board would be the benzodiazepine, but you probably want to optimize the first 2 medications. So lithium, tell me what the routine tests are. You're going to get a baseline and then routinely,
Lithium levels and thyroid level.
right? What do you,
Function as well.
so kidney function as well, right? The other one we usually get is calcium. Right. There is some evidence in the literature that lithium can uncover or unmask an occult parathyroid tumor, so adenoma. So calcium levels, sensitive TSH, thyroid, hypothyroidism, much more common side effect than hyperthyroidism, but sensitive TSH every 3 to 4 months, and then BUN creatinine for kidney function. How do you treat symptomatic lithium toxicity?
Over 4 dialysis.
Yeah, that'll come up. You'll activated charcoal will definitely be answer A. And hemodialysis will be either C or D. So hemodialysis for symptomatic lithium toxicity.
What do you do for asymptomatic lithium toxicity? Just like
Fluids, yeah, fluids, you could diurese them, and of course, hold the lithium.
After that, keep going.
You don't have to, but if your patient has atopy, there could be an eruptive psoriasis as a reaction to the abrupt discontinuation of lithium. I've seen it once. I mean, I'm not a dermatologist, and that may have steered me away from that lifestyle.
Can you be symptomatic less than 4?
Yeah.
Or I guess 4, just like the cutoff word, because I've just seen it to like hemodialysis at 4. But even if you're symptomatic at 2.5.
Yes.
You still dialyze.
Okay.
Yeah, now, I think that in tertiary care centers that are major medical centers, they probably have the resources to forego that. But for the board's symptomatic, doesn't matter about the number. Don't go by the number. Valproic acid, what are your routine lab tests?
Liver function.
Right. What else?
Protein levels.
No.
Analyze.
So if somebody complains of any abdominal pain or any evidence of pancreatitis, yes, get an amylase. Otherwise, we probably don't get it routinely. The other one is consider a CBC, especially platelet count.
So we did thrombocytopenia.
Similar to carbamazepine, same thing. Okay, now what else do you have to consider for carbamazepine?
Stephen Johnson. It's very
Yes,
rare.
yes, rare. I mean, it's more for lamotrigine.
No.
You get it.
I think you can, but I don't know if that's specific to carbamazepine. I think it might be all the AEDs. Diplopia? If you're reading it, then it's true. I wasn't thinking it. The way you looked at it, you stared me down. You're a good poker player. I pulled it quick. So the scenario you're going to get is that somebody comes in with established bipolar, your patient for a long time and has been stable on a static dose of carbamazepine. You write them a script for a month with a couple of refills, bring them back in 3 months. Again, this is a patient you've been seeing for 5-10 years. A week later, you get a call, they're in the ED. Manic episode. What happened?
Is this the one where if you're a smoker, it inhibits like CYP1A and then it increases their turnover?
That's more antipsychotic. That's probably Causeril.
Treats acute mania but doesn't prevent movements.
That is true, but again, in our scenario, they've been stable for like 10 years.
New addition of a drug.
Was that?
New addition of a drug.
No, actually, no new drugs.
Element of tolerance.
Huh?
Tolerance.
Not really tolerance. So it's an autoinducer of 3A4. Right, autoinducer. So it's being processed, it's being metabolized through 3A4, but it's also an inducer, and there's no rhyme or reason. So just keep on reviewing signs and symptoms, early signs and symptoms of mania with your patient. Prescribe carbamazepine, because upon first evidence of any mania, you want to check carbamazepine level, because it may be an autoinduction.
Do you just increase the doses like while you're checking the level, or do you wait?
I would probably add something on. I would
Another
probably,
agent?
yeah, I probably would, yeah. Yeah, I just don't know the mechanism of how, and I would call my pharmacist, of course, but it's probably easier just to add something on that is not touched by 3A4 or not metabolized through, since you know it's now being induced. And then in a similar context, now knowing this, when you provided the informed consent for the individual to be prescribed this medication 10 years ago, when you first prescribed it, what did you review with her?
Oh, yeah.
Was that
Birthday.
birth defects, right? So, and that holds true for valproic acid as well. About 10% incidence of neural tube defects, and even lithium, 1% Epstein's anomaly, right? Atrialization of the right heart valves. But there's something in addition that you have to discuss with your patient that you're prescribing carbamazepine. So when you review with your patient, they should not be pregnant on this medication, right? What is a usual reply you'll get from them?
How old are
No, they're 24.
they? I don't want to take it.
I'm not thinking about that. I don't think.
And why are you so confident you're not going to get pregnant? What are most 24-year-olds going to tell you?
Not actually.
They're
not gonna tell you that.
Mistakes.
Right. So now what do you tell them?
Need 2 hours of birth control.
Yeah, why?
Is it neural tube?
I'm sorry.
Is it the neural tube?
No. No. It's because the oral contraceptive pills metabolize through 3A4. And they are no longer physiologically on the oral contraceptive pill anymore. Right.
So then, would you discharge your from this agent then, or is it like?
It's very helpful to first-line therapy. Not necessarily.
You have to give warnings about like alcohol use too.
Yeah.
Because if you're also taking. It could just be like exacerbated.
Yeah, I mean, alcohol is gonna have a synergistic effect, not necessarily a drug-to-drug interaction, but a synergistic effect with a lot of the medications that are GABAergic, and therefore sedating. So, we always caution and recommend that individuals abstain from alcohol. Don't drink while on this drug now. And even especially for antidepressants, I mean, if alcohol is a CNS depressant and you're giving them an antidepressant, it really doesn't take much to realize that taking a depressant plus an antidepressant is probably flushing both down the toilet. Right, so to give your patient the best shot, and I'm talking for major depressive disorder on your antidepressant of choice, they should steer clear of alcohol until their depression resolves. I don't think there's anything else on carbamazepine. Lithium we talked about, and then the antipsychotics are a discussion separate. All right, we're 10 minutes to the hour. Any final thoughts on Groundhog Day?
Why did they pick that then?
Why did way back pick February 2nd?
No, just like, why is it the movie, like, why the same thing? Is there any reason?
What a terrible day to be.
Right, like, it's just.
I think it's like
Yeah,
February.
I think if it were a more popular holiday, I think there might be some angst as to why he would want to get out of it. I mean, who wouldn't want like a 7-course Thanksgiving dinner every single day? Who wouldn't watch a Super Bowl like 7 days a week forever? So Groundhog Day is fun. It's still quirky. People pay attention, but it may not be at the level where, but otherwise I have no clue. I'll give this one to you. Yeah. I'll give this one to you. All right, we're going to sign off here. Everybody have a great weekend. We will post both the Seinfeld episode as well as next week's film on Twitter, if not tonight, very, very soon.
We won't be.
Your shelf next Friday?
Will you ever divulge what Friday is actually?
I didn't see you guys up there. I will.
Keeps me up at night.
If you ask, I will. Let me just.
Better questions.